Here's our high-yield arc for today. First, classification. Second, management. Third, key clinical pearls. Fourth, classic exam traps. And finally, we'll wrap up with a quick recall question.
All right, Section 1, Classification. Okay, so the AAST liver injury scale grades trauma from Roman numeral I to V. Now, thinking about the typically non-operative green and yellow grades, that's I, 2, and 3, you really want to pay close attention to the mathematical progression. It's all about those cutoffs, right? For a grade I subcapsular hematoma, it covers less than 10% of the surface area, and any lacerations are less than 1 centimeter deep. But watch how those numbers jump for grade 2. The hematoma grows to between 10 and 50% of the surface area, intraparenchymal hematomas sit under 10 centimeters in diameter, and lacerations deep into that 1 to 3 centimeter range. By grade 3, well, things are getting serious. Subcapsular hematomas are now over 50% of the surface area, or they're actively expanding. You might also be looking at a ruptured hematoma, an intraparenchymal hematoma greater than 10 centimeters, or a laceration deeper than 3 centimeters. Getting these exact thresholds memorized is absolutely crucial for nailing your classifications on the ward.
Moving into these severe orange, red, and black grades, notice how the criteria just dramatically shifts. We're no longer talking about centimeters of laceration depth here. For grade 4, we're talking massive parenchymal disruption, involving 25 to 75% of a hepatic lobe, or involving 1 to 3 quinoid segments within a single lobe. Grade 5 pushes that even further, meaning parenchymal disruption of over 75% of a hepatic lobe. But here's the kicker. Grade 5 also introduces a critical vascular component. We're talking juxtahepatic venous injury, which includes the retrohepatic vena cava or major hepatic veins. And finally, there's grade 6, which is hepatic avulsion. Honestly, this is generally considered a devastating, often unsurvivable injury.
Let's move on to Section 2, Management.
So, how does this anatomical grading actually dictate your clinical management? Well, it all comes down to the classic dichotomy of trauma care. First, let's talk about the pathway for a hemodynamically stable patient. For stable patients, even those with high-grade injuries all the way from I up to V, non-operative management is actually preferred for most blunt injuries. That means observation, serial clinical assessments, tracking their hemoglobin and hematocrit, and getting a CT with IV contrast. If there's active arterial bleeding, angioembolization might be the way to go. But on the flip side, if the patient is unstable despite resuscitation, you absolutely must abandon the non-operative path. An unstable patient mandates immediate operative hemorrhage control, period. You do not delay a laparotomy just because you don't know the CT grade yet.
So, let's play it out. Say your patient is unstable. We immediately transition to damage control techniques in the operating room. Your main goal here is immediate operative control. You might use perihepatic packing to apply direct pressure. You might utilize the Pringle maneuver, which we'll actually discuss in detail in just a minute. You'll be using topical hemostatic agents, securing vascular control, and performing selective repair or resection only when absolutely necessary. Remember, in damage control, the goal is survival and stopping the bleed. It is not about a perfectly definitive anatomical reconstruction on day 1.
All right, jumping into Section 3, Key Clinical Pearls.
The underlying principles that separate good test takers from truly great clinicians basically come down to one golden rule, captured perfectly by this idea. Physiology determines management more than anatomical grade. Honestly, if you take only one thing away from this explainer, let it be this. The AST scale is primarily anatomical, right? It tells you what's broken. But the patient's hemodynamic status tells you what to do. A grade 5 injury in a perfectly stable patient might actually be managed non-operatively in the right trauma center, assuming there are no other injuries requiring a laparotomy and adequate monitoring is available. Always treat the patient's physiology first.
Now, another incredibly testable pearl is the Pringle maneuver. This temporarily occludes the portal triad. Basically, you're clamping off the hepatic artery, the portal vein, and the common bile duct. This completely stops the inflow of blood to the liver. But here is the massive clinical pearl. If the bleeding continues profusely, even after a successful Pringle maneuver, you know right away the bleeding is not coming from the inflow. You must immediately suspect an outflow issue, specifically a retrohepatic vena cava or hepatic vein injury.
Section 4, Classic Exam Traps.
The first major trap examiners love to use is testing your knee-jerk reaction to a high-grade injury. Remember, a grade IV does not automatically mean surgery.
Like we established earlier, a hemodynamically stable patient with a grade 5 injury might still be managed non-operatively in a proper trauma center. Don't let that scary Roman numeral trick you into picking the immediate laparotomy option if the prompt clearly tells you the patient's vital signs are stable and normalizing. For trap number 2, you really have to lock in the exact numbers. Examiners just love testing the boundaries. AST grade 4 specifically means 25 to 75% of a hepatic lobe is involved. If it's less than 25 or more than 75, it's a completely different grade. So make sure you memorize that specific 25 to 75 window. Trap 3 reminds us that grade V isn't just about the lobe percentage exceeding 75%. It also specifically includes major juxtahepatic venous injuries. So if an exam question describes a liver laceration with involvement of the retrohepatic vena cava, boom, that is an automatic grade V. And that's regardless of the parenchymal disruption percentage. And finally, trap 4 tests your anatomical logic, building right on our earlier pearl. The Pringle maneuver only controls inflow from the portal triad. It absolutely does not control hepatic venous or retrohepatic caval bleeding. If an answer option suggests the Pringle maneuver will solve a retrohepatic bleed, I promise you it's a trap.
Okay, last up, Section 5, a quick recall question.
Let's lock this knowledge in. A hemodynamically stable patient has a liver laceration involving 40% of one hepatic lobe. What is the AAST grade? Take a second and think about the percentage thresholds we just went over.
And the answer is grade 4. This perfectly illustrates our 25 to 75% rule for grade 4 injuries. If it were over 75%, we'd be looking at a grade V, but because it sits right at 40%, it's a solid grade 4. Which leaves us with one final, absolutely critical thought to carry on to the wards or into your next exam. When the pressure is really on, are you letting the anatomical CT scan dictate your surgical response, or are you correctly treating the patient's underlying physiology? Thanks so much for learning with me today, and keep that crucial question in mind the next time you're reviewing a trauma case.